So let's start. Am I audible now? Is the voice coming? Ankit? Anita? Actually, the mic was mute. I think now the voice is coming. Chalo. So let's start. So we are starting the session now. Okay. So let me start the class. So now we'll be discussing the cardiology, and just before that, nephrotic and nephritic. I think that part was missed. So remember, if there is what, I'll discuss the nephrotic and nephritic. तो शायद छूट गया था हमारा, चलो कर देते हैं उससे भी, आ जाओ. So what is nephritic and nephrotic वाला फंडा? देखो, so first, if there is a proteinuria, that is mainly albuminuria. If there is also RBC present, that is RBC cast, Coca-Cola urine, Coca-Cola urine, then it is our nephritic syndrome. Nephritic syndrome, okay? And in case there is what? In case there is what? There is no RBC cast, no RBC, and the urine is cloudy urine. It is nephrotic syndrome. Then what is the proteinuria here? The proteinuria here is more. Here non-selective proteinuria, less than how much? Less than 2.8 gram per day. Here it is very selective one. Selective, more than 3.5 gram a day. Plus there is dyslipidemia, cholesterol, all dyslipidemia, then infections, etc. ये बन गया नेफ्रोटिक सिंड्रोम, ओके, इन्फेक्शंस एक्सेट्रा. अब नेफ्रोटिक में याद करना, अगर न्यूबॉर्न है ट्रीटमेंट याद कर लो, एंड देयर इज आल्सो हाइपरटेंशन हियर. Hypertension. So where is hypertension associated or seen? Hypertension is mainly seen in this particular case. Are you clear? So hypertension is basically hypertension. Okay. Now treatment. Steroids. If don't work, immunosuppressants. Example, क्या देना है? Cyclophosphamide. So we can give the person cyclophosphamide. What else? Also we can give them azathioprine. And what else? Yes, rituximab. Rituximab. Okay. Here also same treatment. Add ACI also. Add what? ACI. Add the ACI. ठीक है. अब डिजीज कौन सी है याद कर लो. इसमें अगर एडल्ट है तो IgA नेफ्रोपैथी. IgA नेफ्रोपैथी बर्जस. वर्जिक्स। और अगर चाइल्ड है PSGN, post streptococcal glomerulonephritis. So if a child come with Coca-Cola urine, think PSGN. If an adult come, then you think Berger disease. Are you clear? And here same, अगर child है, what is the disease? बताओ भाई, बिलाल भाई, बिलाल और बाकी बच्चे, बिनिन, बताओ बच्चा, क्या दोगे इसमें? चाइल्ड है तो antibiotic are not very effective. You can ignore the antibiotic. Uday, why? Because I told you it occur after immune complex deposition. So that's why technically it is what, not related to antibodies or antibiotics are much used, because there's no infection as such. So that's why we can ignore it. We can ignore it. Okay. Chalo. Minimal chain disease. Minimal change disease. Okay. Next, what is there? Adult में FSGS या FSGS. ठीक है, चलो ये हमारा हो गया किडनी भी पूरा. Let's do cardio now. Let's do cardio. So yes, adult is FSGS. Treatment is same, steroids. इन डाउनलोड्स में है. बताए तो रेजिस्टेंस के लिए इम्यूनोसप्रेशन सुल्तान वी गिव साइक्लोफॉस्फेमाइड. आर यू क्लियर? ये तो मैंने सेव की थी यार. कोई नहीं, मैं डाउनलोड करता हूँ टेलीग्राम से. लेट्स स्टार्ट. ये रहा है. कई बार इतनी सारी फाइलें आती है, मिलती नहीं. दैट्स द बिगेस्ट प्रॉब्लम. You yourself cannot find the file you yourself were putting. ऐसा बड़ा बुरा लगता है, दिल से बुरा लगता है भाई. ये बताओ, सर्च करनी पड़े. ओके, सो लेट्स स्टार्ट. Okay, so let's start. First is who's the pacemaker of our heart. So pacemaker of heart is SA node. Okay, and then our slowest conduction is where? So slowest conduction occur in which area? It occur in which area? It occur in our AV node. That's why it causes maximum block. AV block is here, which I'll discuss later. And fastest is Purkinje fiber. What are the waves? Atrial devolution cause P wave, ventricular D cause QRS, and the re causes the T wave. खत्म. चलो हार्ट की बात करते हैं. व्हाट इज द ब्लड सप्लाई ऑफ द हार्ट? सो लेट्स हैव अ लुक. फर्स्ट इज इन द हार्ट द inferior wall is made by the right ventricle and it is supplied by right coronary artery. So what is right coronary artery? Supplying inferior wall, and it is given in the ECG by what leads? 2,3 AVF. So what leads? 2,3 AVF. Whereas the left coronary, it has two branches, LADA and CX. What is CX? Circumflex. It supplies the left ventricle, you can see. And left ventricle is the lateral wall of the heart because on the left side. And it is having which ECG leads? It has the leads AVL, A, AVL, 1, V5, V6. So lead 1, AVL, 5, 6. They are what? Lateral wall. Then come the LADA. What is LADA? LADA is our left anterior descending artery. It supplies the anterior wall and part of the left ventricle, and it is basically V1 to V6. That is the entire LADA. Septal is V1, V2. Anteroseptal V1 to V4, and anterolateral is V3 to V6. Is V3. Now, the most common artery involved in what? Coronary artery disease. So once again, what are the most common artery involved in coronary artery disease is what? It is our, yes, LADA. सो कार्ड में लाड लगता है, इसे बोलते हैं कॉर्नरी आर्टरी डिजीज में लाड लगता है. सो कार्डा लाडा, and it is also called as widow's artery. Why widow's artery? Because males are affected more than the female. So that's why husband die and the wife become a widow. So that is why husband die more. Okay. And what are the most common cause of atherosclerosis? It is, yes, it is our diabetes mellitus, obesity, then dyslipidemia, diet, lack of exercise, genetics. Okay, then we diet, alcohol, etc. So these all are what? These all, yes, बिल्कुल बिल्कुल. So लाडा काड़ा बहुत सारे पढ़े हमने. चलो, now coronary arteries में क्या होता है? There is a ischemia, and what does ischemia cause? Obviously, it causes a chest pain, which is called as angina, and also there's an increased heart rate, palpitation, sweating. The person is in intense pain, like this. This is called as Levine sign. So the clenched fist over the chest is called as a Levine sign. And now question: there are two types of angina: angina, classical angina, and variant. So remember, very simple. S, X. So your X is S, exertion. तो जो exertion से, emotion से, feeling से आए, उसे बोलते हैं classical. Example: you tell your exam result, class test marks to your parents. Your parents start having chest pain. What is it called as? It is called as your classical angina. Are you clear? Whereas variant is at rest. कैसे याद करना? Variant is rest. Class C is exertion. And it is also called as Prince हेलो भाई, हेलो, प्लीज चेक इट, इट्स बैक, इट्स बैक, इट्स बैक, इट्स बैक, आ गया भाई, आ गया, आ गया। मत दुखी हो भाई, लाइफ में ऐसे होता रहता है, लाइफ इज ऑल अबाउट दिस कमिंग एंड गोइंग। आ गया भाई, आ गया, आ गया, चलो। सो प्लीज रिज्यूम। हेलो भाई, हेलो, हेलो, आ गया, सबका आ गया, आ गया ना ये। लाइफ में चलता रहता है भाई। सो शुड आई स्टार्ट नाउ? नीतू, रैगिट के, बिलाल, कर दो भाई स्टार्ट। सॉरी। ओके, ओके, लेट्स कंटिन्यू। फाइल भी बंद हो गई। चलो लेट्स स्टार्ट। ओके, चलो। Okay, so let's continue. So now, first is, so if there is pain on exertion, activity, etc., what is it called as? It is called as our classical angina, and the pain is relieved at rest. Okay, drug of choice is nitrates. We can give also aspirin, CCB, beta blockers. Beta blocker decrease the heart rate and are very beneficial. Okay, now in variant, which is also called as Prince metal. What is variant also called as? Variant is also called as what? Prince metal. Here there is a vasospasm, and as the vasospasm occur, the blood supply will decrease, and blood supply decrease causes the pain. Here we again give the nitrate sublingual, but never use beta blocker. Okay, what is the drug of choice? CCB is the drug of choice. So vasoactive CCB is drug of choice. Okay, चलो। कोई बात नहीं, उनको बोलना आशीष सर किसी नेक काम करने के लिए पैदा हुए हैं, ही इज डूइंग समथिंग गुड एंड ही विल डू दैट गुड थिंग। ओके, सो दैट इज व्हाई। ओके, so sometime you are here for greater purpose in life, not making babies. Now now comes the question. Okay, so stable angina, the pain is relieved within 10 to 15 minutes at rest, whereas we will do what we will do, and if not relief, it is our unstable. If not relief, it is unstable. Okay, clear? At rest and worsen in unstable. Unstable angina और MI. सो MI और अनस्टेबल में पेन बिल्कुल भी नहीं बैठता, ये बढ़ते रहता है। ठीक है, नाउ व्हाट यू डू, you ask the person to undergo screening test. In stable, we do screening test called as stress test. Either we ask the person to do the exercise on the treadmill called as Bruce protocol. So we run on the treadmill and we check the yes is ECG changes. What are the ECG change? ST depression for more than 1 mm for more than 80 millisecond in 2 or more loop, and we use the Duke scoring. So what score? Duke. If the person cannot run, we ask him, okay, we'll give you dobutamine which increase the heart rate and do the test. इसे क्या बोलते हैं? It's called as ड्रग स्ट्रेस टेस्ट, क्या बोलेंगे इसको, ड्रग स्ट्रेस टेस्ट. Now next question, if CAD ischemia occur and the positive test is what, ST depression more than 1 mm for this. Now for confirmation and the site of the block, number of the block, all, we will do angiography, and after angiography we will start the medical treatment. Medical treatment, what drugs we use, aspirin, beta blockers, then anticoagulants, okay. Also important is what, yes, plus lifestyle modification, all this, aspirin, beta blocker, lifestyle, all, okay. And either PCI or CABG, and the treatment of choice, TOC. So first we do medical treatment. In medical treatment we give aspirin plus lifestyle modification, all this, healthy living. So treatment of choice is basically either PCI or we will do what is CABG. It is what? It is CABG. Now, what is CABG and this? Basically, angioplasty is percutaneous intervention. Here we will dilate the vessel and put a stent. That is the case. Or we can do is CABG. CABG is coronary artery bypass grafting. It is done in rare condition. Why? It's an open heart surgery. We have to put a graft and connect the vessel, which require you to have at least some access to the thorax. So that is the case. And it is done in rare condition, like it is done in triple vessel disease. So when 3 vessels are affected, we will do this. So triple vessel disease. Then what we can do in double vessel with LED involvement, Then left main coronary artery disease. If the left main is affected, we have to do the we have to do our bypass grafting. Are you clear? Best graft is Lima, which is left internal mammillary artery, or if not available, we can use saphenous vein also. Are you clear? Now the drugs as I discussed was aspirin, clopidogrel, which are antiplatelet. Then we can use the heparin, LMWH, or that low molecular weight heparin. Example is enoxaparin. So what is the result is? It is our enoxaparin. So what is that is? Enoxaparin. Then abiximab, which is again an antibody, monoclonal antibody, which is against the glycoprotein 2B and 3A, prevent the clotting. Then beta blocker, CCB, statins for dyslipidemia, lifestyle, exercise, all are to be given. Okay. Now, unstable angina, basically what? The pain is more than 15 minutes, not relieved on rest or even by nitrates, and it keep on worsening. That is crescendo pattern, keep rising, and it's an emergency. And what is it called as? It is called as acute coronary syndrome. What is it called as? ACS. What is ACS? Acute coronary syndrome. Now, acute coronary syndrome can be MI also, or it could be unstable angina also. What it can be? It can be MI, or it can be unstable angina also. So what are the two options? It is MI or it could be unstable angina. Now what we need to do? We will do MONA. MONA is what? Our morphine, oxygen, nitrates and aspirin. Then we need to do what? Is ECG. What we need to do? ECG and also biomarker. So remember, ECG is the best, then come biomarker. Okay. Now, what happens in MI? So myocardial infarction, there is what? There is a coagulative necrosis due to prolonged ischemia. So there is a coagulative necrosis. Then it will release potassium and biomarker in the blood, which causes our arrhythmia, and ECG changes. What changes? ECG changes. Now, what is the first change? First change in ECG is what? Tall T wave. This is called as what? The tall tented T wave. Also occur in hyperkalemia. Then there is ST elevation after 3-4 hours. This is called as Pardy sign. Which sign? Pardy. So what is the elevation is? It is our Pardy sign. So once again, Pardy sign is ST elevation. Are you clear? And there is what? T and ST combined call as what? Tombstone sign. So there is now this appearance. So ये याद कर लो जहां भी there is first tall T wave and the elevation of ST. This is the hallmark of MI. Third change is T wave invert. So that become biphasic. That is, you see a downward going and also inverted T wave. And finally, there is pathological Q wave. Pathological Q wave appear after almost 24 hours and they persist all life. So what persists all life? Pathological. ST and T become normal after few weeks. But what stay all life? Q. That is why if you see only Q changes, suspect old and far. If you see Q with all this indicate acute MI. So that is acute MI. So how do you differentiate acute MI from a old one? The answer is Q wave or the ST changes. Give an idea. Are you clear? Now let's discuss what is there. So inferior wall, what will you see? Inferior wall MI. So we will see the elevation in 2-3F and we can see a depression in AVL and 1. So where do you see the elevation? Inferior wall. We see elevation in what? Elevation in 2-3 AVF and a depression in what? Depression in AVL and 1. That is the marker of inferior wall MI. Now, what is first to rise? It is hard fatty acid binding protein, also called as HFABP. In what time? Around 30 minutes. And then what rises? Myoglobin will rise. So what rises next? Myoglobin. For what time? 1 to 3 hour. 1 to 3 hour. The most specific is what? Most specific is our troponin T and I. I is best for MI. For reinfarction, we should use CKMP. उसको चेंज कर लो. Reinfarction CKMP. थोड़ा change it. Reinfarction CKMP. And then there is also LDH flip. What is there? LDH flip. What is LDH flip? Normal heart, you see that LDH2 is more than 1 in the blood. But if there is a MI, after MI, the LDH flips. The 1 become more than the 2. So what become more? 1 or 2? Yes, the 1 become more than the 2. So what is more now? 1 is more than the 2. 1 is more than the 2. That is called as LDH flip. Now treatment. If ECG normal and biomarker negative, it is unstable angina. If anyone is positive, if biomarker positive, it is MI. It is MI. Now we check the ST changes. What we look for? Check ST elevation. Check ST elevation. Pay attention. If it is elevated, it's called as STEMI. What is it called as? It is called as the STEMI. And if it is normal, it is called as non-STEMI, NSTMI. Okay. Now remember, if it's a STEMI, we can do thrombolysis. Can do. It's not like we do. Can do. If PCI not possible. If PCI is not possible. Are you clear? In non-STEMI, never do thrombolysis. So remember, non-STEMI में बोल ही रहा है वो नहीं करना thrombolysis streptokinase. साथ में UA. What is UA? Unstable angina. So please remember, no thrombolysis in what? Non-STEMI and unstable angina. Are you clear? So what is the only thing we are giving? We give morphine for pain, then we give oxygen, we give it IV, then nitrate, nitroprusside, basically decrease the BP and vasodilation. But remember, avoid in inferior wall MI. Avoid it. And aspirin we give chewable form. 325 milligram is the value. So what are the values? 325 milligram. क्या आएगी value? 325. Are you clear? चलो Now, antiplatelet drugs. What drugs? Antiplatelet drugs like clopidogrel, enoxaparin, beta blocker, CCP. If nothing, if no relief, we'll give a delayed PCI. What's delayed PCI? Here we do full examination, analysis, and then we take a decision. It's like a not, see, there are two kinds of surgery. One is emergency and one is a elective surgery. Elective means we plan like hernia. In hernia, obviously it's not obstructed or some kind of strangulated. If it is hernia which is non-obstructed and not strangulated, obviously we can do the surgery on proper time. So are you clear? Now comes the next question. What is the next question? If it's a STEMI, then what is the treatment of choice? Is PCI. Okay, and streptokinase we might do or we might not do. Okay, clear? So एक काम करो, उसको मैं निकाल रहा हूँ यहाँ से because I don't think it is making good sense to keep it here. तो ये गलत निमोनिक है इसका, ये मोना और समोना भूल जाओ उसको, गलत निमोनिक है इसका। क्या है, पहले मोना दे दो उसको, ठीक है। एंड ट्रीटमेंट ऑफ चॉइस इज PCI, अर्ली PCI, ओके, दैट इज एंजियोप्लास्टी। And the door to balloon time, that is time taken for patient to bring from his house door till the insertion of balloon and inflation of balloon should be 90 minutes is the best time, and up to 120 minutes. If not possible, then you can inject streptokinase for thrombolysis. So remember, when can you give the thrombolysis? If it is not possible to do it in this time, okay, streptokinase, okay, for thrombolysis. What is the time for the injection? 30 minutes up to 60 minutes, up to 60 minutes. Are you clear? Very important question. Now remember one rule, if it is inferior wall MI, क्या है ये? Inferior wall, then obviously IV fluids, inotropes, and we can give MOA, but not MONA. क्यों? Nitrates are contraindicated, so also don't give nitrates. And also, yes, morphine can be given, nitrates, and avoid morphine, avoid nitroprusside क्योंकि already BP is low. And also, yes, there is hypotension and bradycardia. तो क्या है इसके अंदर? Hypotension, bradycardia. So we give inotropes, we don't give what? The beta blocker. Also avoid beta blockers. So beta blocker, nitroprussides should be avoided in this case. Are you clear? Next question. What is hypertension? So older criteria was 140 by what? 90. That is the older criteria. Now the new criteria is 130 by 80. Even India we use 130/80 as the new criteria for hypertension, and it follow rule of half. Like half the patients will be recording their BP, will be tested. Out of that, the half of the patients will actually be labeled as hypertensive, other will be missed, or they will not come for another test or this. Then half will be given treatment, half will take it properly. So very few people are actually, see, hypertension is very much manageable disease. It's very much not preventable, but it can be treated to some extent without much causing problem. It's the patient who's not taking care, not taking the medicine on time, skipping them. They are the one who suffer more and more. Okay, so they suffer more. Are you clear? And it also show iceberg phenomena. That means very few are the actual patient who are diagnosed or identified. Rest remain hidden. Now there are two kind of hypertension. Primary is 95%. It is idiopathic and there is no other disease. It's just high BP. There is no other disease, diabetes, etc. Secondary occur in case there is a renal artery disease like glomerular disease, nephritic syndrome, or Cushing, Cone, SLE, pheochromocytoma. All these are called as what? These are called as secondary hypertension. Now, in case of this hypertension, it is called as silent killer. Why called a silent killer? Very few or no sign symptom. Whatever is there, there is headache, sleep disturbance, irritability, malar flush, etc. They are there. Now, management. For management, what we can do? most effective is decrease the BP is by weight loss. So weight loss karana, because obese people will be mostly diabetic also, and they are the one with have hypertension also. Okay, then decrease the salt less than 2.3 okay gram per day, and also stop the alcohol and this, and also lifestyle modification. Okay, so I hope it's clear. Now, drugs used whenever patient has hypertension. So what are the drugs used? First is, we start drugs only when the BP is above 140 or 90. So once again, don't use the drug if the BP is less than 140/90. When is the BP? See, 130 you can diagnose and start lifestyle modification or भी बतेरी चीजें. लेकिन medical treatment should be started. Medical treatment should be started only when the BP is above 140/90. Is it clear to all of you? So when should you start the treatment? When it is above 140/90. Otherwise, there's no point doing it. Are you clear? Chalo. Now let's continue. First is, what is the first thing we will see, discuss or have? It is diabetes mellitus. Okay, so in case of diabetes mellitus, okay, or age above, yeah, less than 60 is the criteria. So if the age is above 60, go for CCB. Go for CCB. Which one? Like amlodipine plus diuretics. Okay, and if the age is young or patient is diabetic, then we go for ACE. Which is ACE or ARB? Very commonly used valsartan, and which CCB? Amlodipine. So that's why lots of your relative might be taking this. Then if it's not controlled, we have to add what? We have to add CCB plus ACE inhibitor. We have to add ACI if not controlled. Clear? And if controlled, so then we can continue. Then if still not controlled, we have to add diuretic, A plus C plus D. So now the treatment become A plus C plus D. A plus C plus D. Okay. Chalo. Now, next is, if still not controlled, it is called as refractory hypertension. Or the drug of choice? Drug of choice, spironolactone. But remember, okay, avoid if high potassium. Use beta blocker. ये क्वेश्चन आया था. So always check potassium level. If they are on the higher side, let's say 4 point, not hyperkalemia, or 4.5 or above, then better we go for beta blocker. So remember, spironolactone should only be used when the potassium is on the lower side. If it is higher side, use a beta blocker. Are you clear? Now there is something called as hypertensive emergency or the urgency. What is the BP? It crosses 180/120. So what is this BP above 120/180 called as? The 180/120 is called as the, yes, hypertensive emergency or urgency. Remember, urgency you can manage in the OPD. OPD, give treatment, okay, send home. In case of emergency, it's end organ, admit and treat. Now, if preeclampsia, obviously the drug of choice is IV, labetalol. If stroke plus SAH, we use nicardipine, clofazimine, or CCB, or labetalol, which I taught you already. Labetalol. Then, if there's pulmonary edema, if there's a pulmonary edema with systolic dysfunction, Obviously, we are going to use loop diuretics for pulmonary edema is a drug of choice. So loop diuretics are the drug of choice for edema. ये क्वेश्चन बहुत बार आया आपका, फिर से कलर कर देते हैं इसको. But if it is with systolic heart failure, we will give nitroglycerin with nicardipine, which is a CCB. If diastolic, we add asmolol with NTG plus loop. Avoid, yes, CCB, use asmolol. Then if there's a dissection of aorta or MI, we use BC, beta blocker like asmolol plus CCB, nicardipine or labetalol. Okay, asmolol, or we can use labetalol. So what we can use? Labetalol, because it's both alpha beta blocker. Asmolol is the shortest acting beta blocker. Now recently there is one more beta blocker introduced, which is now the shortest acting beta blocker. Are you clear? So clear now? Chalo. Next thing. Chalo. So landiolol. So what is now the latest one? It is landiolol. So ठीक कर लो. अगर by chance आ गया shortest acting, तो उसका आंसर है landiolol. Landiolol. Okay. So land करा देगा ये आपका, ठीक है? So landiolol. Are you clear? So landiolol. ये 3 to 4 minutes और 9. तो अगर पूछें ये better answer है. It's the best answer. Landiolol is best. ठीक है? It's just 3 to 4 minutes. 3 to 4 minutes. Are you clear? Landiolol. Now, if there's a kidney disease, then we give a D1 agonist called as phenyltopam. And pheochromocytoma इतनी बार पढ़ाया मैंने, labetalol plus phentolamine. Labetalol plus, तो एक बार summarize करते हैं. Mainly remember you have to mark CCB और labetalol, which is beta blocker. That's it. इसी में आपका क्वेश्चन निकल जाता है, ठीक है? चलो. Now next is heart failure. What is heart failure? If heart fail to pump blood properly, obviously the blood supply to the body is hampered. There is a heart failure. Okay. In heart failure, there is going to be what? A cardiogenic shock plus congestion is there. So what are the finding? It is cardiogenic shock and congestion. Okay. And remember, congestion could be in the lung, pulmonary. If it's a pulmonary, what is the most likely feature? It is left heart failure. Clear? Yeah, landiolol. Very good. क्या बात है? Yes, it is used in atrial flutter and fibrillation as a rate control agent. क्या बात है बिनिन? बिनिन हमेशा अपडेट रहती है. Very good, शाबाश. And if there is a, yes, so systemic, that is in the body. Systemic means body, like pedal edema, pedal ascites. चलो. Next question. What are the other findings? Decrease stroke volume, cardiac output, BP. But heart rate increase because as the BP decrease, the baroreceptors, etc. sense the BP and there is an increased sympathy to correct the condition. And that's why there is a tachycardia. Chalo. Next question. If BP is maintained, it is compensated heart failure. If not, it's unstable, hemodynamically unstable or decompensated. Now, there are two kinds of heart failure, systolic or diastolic. In systolic, pumping is bad, like MI, myocarditis, ventricular fibrillation, or any kind of dilated cardiomyopathy or cardiotoxic drug like doxorubicin. If heart is damaged, it is your systolic. Whereas if less filling like CP, CT, restrictive cardiomyopathy, suspect what? Diastolic heart failure. Suspect what? Diastolic heart failure. Then what are the findings? Main is ejection fraction. If ejection fraction, they ask, ejection fraction is reduced in systolic. That's why it's also called as, yes, heart failure with reduced ejection fraction. Also called as this ref. What is it called as? Ref. Reduced ejection fraction. And since the blood increases in the heart and dilated, it causes cardiomegaly. And what is the sound heard? It is our gallop rhythm. So S3 gallop rhythm. Okay. Treatment is inotrop. One of the inotrop is digoxin, or if they ask drug of choice, nowadays the drug of choice has become our noradrenaline. Okay, noradrenaline, inotrops. Now diastolic heart failure. In diastolic heart failure, the filling is less. So what is less? Filling is less. So filling is less, and there is this constrictive pericarditis, tamponade, or any kind of tumor in the mediastinum all. Now there is a decrease filling. So EDV decrease, but what is preserved? Ejection fraction is preserved. ये कितना होगा? It will be above 50%. ये सबसे बड़ी इसकी मार्किंग है. अगर 50% से ऊपर है मतलब ejection fraction is not affected. An example is cardiac tamponade CT. इसमें JVP show what X present, Y absent. तो X ने काट दिया. तो किसने काटा? X. Cut. So cut is X. Cut is X. And there is a which stride? Back stride. What is back stride? Decrease BP, venous distension, so neck veins are engorged, and there is muffled, unclear heart sound. Treatment is pericardiocentesis. Pericardiocentesis. ठीक है? And if there is X and Y both present, वो आगे आएगा शायद मेरे ख्याल से. Yeah, that will be there later. So अगर X and Y दोनों आ गए तो क्या बन जाएगा? If X and Y both are present, तो ये क्या बन जाएगा आपका? If X and Y. If X and Y both are present, it is which condition? This is your constrictive pericarditis and also Kussmaul is positive. Okay, तो उसको मैं कलर कर देता हूं क्योंकि अलग ही टॉपिक है. Tamponade में X and Y are positive. So tamponade में X, Y. Okay, and in constrictive pericarditis CP में X भी positive, Y भी positive. दोनों positive है. X, Y both positive. X and Y both are positive. So who's positive? X also, Y also. X also, Y also. Okay, and also Kussmaul positive. In tamponade, Kussmaul is negative. Okay, and also Kussmaul negative. So remember, if Kussmaul is positive, suspect CP and also XY positive. So remember, all three are positive. X, Y, K. All three positive CP. And if there is only X, no Y, no Kussmaul, it is tamponade. And tamponade is what positive? Back's positive. Back's positive. Just 1 minute, okay? I'll come with my water. I'm back. Let's continue. So now next question. Okay. एक बार रिवाइज करते हैं. देखो आपका सबसे बड़ी बात क्या है, वो है यू शुड हैव अ वेरी गुड बेसिक कंसेप्ट अंडरस्टैंडिंग. नो वन नीड टू नो एवरीथिंग. तो बेसिक आइडिया दे रहा हूं, उसको याद कर लो एंड आई थिंक दैट विल हेल्प. फर्स्ट, इफ दे आस्क यू द बेसिक थिंग्स, द मोमेंट दे से चेस्ट पेन, सस्पेक्ट व्हाट? सस्पेक्ट एमआई एंजाइना. ईसीजी कर लेंगे, पता जाएगा. ठीक है, फिर होगी. ठीक है, अगर फीचर आ रही है आपको, क्या आ रही है मतलब अडीमा वाला, अडीमा वर आ रहा है अगर आपका, तो अडीमा मेनली हार्ट फेलियर की फीचर है. ये है फेलियर. ठीक है, ये फेलियर हो गया, अडीमा वर आ रहा है. ठीक है, फिर अगर जेवीपी वाले क्वेश्चन आ रहे हैं तो ये मेनली सीपी और सीटी होता है. बस आओ देख लेते हैं इसको भी, सीपी और सीटी. आओ देखते हैं कैसे. तो क्या याद करना है, सीपी में क्या आएगा, क्या क्या पॉजिटिव है, क्या क्या नेगेटिव. एक्स, वाई और कुसमॉल. Who's positive, who's negative in CP? एंड इन सीटी क्या पॉजिटिव आएगा? बताओ भाई, शुरू हो जाओ। ऑल थ्री पॉजिटिव इन सीटी, बस ये याद कर लो। इन सीटी सिर्फ एक्स आएगा, बाकी कुछ नहीं आता, और साथ में आएगा बैक स्ट्रैंड। खत्म, इसी में क्वेश्चन सॉल्व। वेरी गुड, इसी में क्वेश्चन सॉल्व हो जाता है मैक्सिमम टाइम्स। ओके ओके, नाउ नेक्स्ट क्वेश्चन। If there is a, yes, left heart failure, the most common cause is left heart failure for right heart failure. And if there's a left heart failure, it's mainly because of the, yes, long standing diseases like hypertension can cause, or even MI can cause. That's the case. Now remember, if there's a right heart failure, the blood will not go to lung. So that's why it causes cyanosis and poor oxygen exchange, hypoxia. So hypoxia, cyanosis is more worse in right heart failure. Then there's the congestion in the feet, which is pitting in nature. So it's bilateral pitting edema, bilateral pitting edema in the feet. The JVP tends to increase. So what increases? JVP will increase. So what increases? JVP will increase. Also what increase? The pressure increase, the H2O. Then ascites is there. What is there? Ascites is there. Also there is a hepatosplenomegaly, and there is a CVC liver, which give a nutmeg appearance. It look like this supari or jaffle, whatever. Then also is a hepatojugular reflex or reflux, where when you press the abdomen over the liver area, it causes the pushing of what? It causes the pushing of the blood towards the heart. So that is hepatojugular reflex or reflux. Okay. So clear? Okay. Now come pulmonary edema. So in case of pulmonary edema, what do we see? So first is X-ray. We see bat wing appearance, then curly B lines. They are the markings of pulmonary edema. Then there's a cardiogenic shock because the pumping is not possible. Then there is increased sweating due to sympathetic, so sweating increases. Then there is what? Decreased urine output, cold skin, fatigue is there. Okay, yeah, fluid thrill is there, which is for ascites and shifting dullness. When you turn from one side to other, the fluid will always go to the lower or dependent part. Okay, then person has PND. What's PND? Paroxysmal nocturnal dyspnea. So when the person is sleeping and he will wake up with severe dyspnea. What is it called as? It is called as our paroxysmal nocturnal dyspnea, PND. Then there is what? Breathlessness on lying down. It is called as orthopnea. What is it called as? It is called as orthopnea. Then there is S3 gallop rhythm. What is there? S3 gallop rhythm is there. Also there is dyspnea on exertion. So what is there? Dyspnea on exertion is there. Plus also there are basal crepitation. What is there? Basal crepitations, that is the crepitus, the sound, the bubbling sound is there at the base. Plus it could be sometimes louder, called as crackles. Then when he inspires, this causes a air fluid mixing that cause the rails, and also this pink frothy sputum because of RBC. Actually it is RBC in the sputum. So all these are finding out pulmonary changes and left heart failure. Investigation, we do echo, and we also do BNP. What is BNP? Yes, brain derived natriuretic peptide. X-ray, Muga scan. What is Muga scan? It is for ventricular functioning. So Muga is multi-gated acquisition scan. It's an isotope study, very similar to our this RAIU, multi-gated, yes, acquisition scan, multi-gated acquisition scan. Are you clear? Called as our, yes, Muga. Now, what is the criteria? So remember, if your heart fail, you will die. You will die. And if you die, यू आर इन अ फोटो फ्रेम। तो किस में आ गए अब हम? फ्रेम। तो फ्रेम में हम कब आ जाते हैं? फ्रेमिंगम। सो फ्रेमिंगम इज द क्राइटेरिया। द क्राइटेरिया फ्रेमिंगम। ओके, what is Framingham? It's a combination of which criteria? Right heart and left heart failure. Let me show you. So this is pulmonary edema, cardiomegaly, hepatojugular reflex, neck vein distension, PND, orthopnea, Rales, and S3 gallop. All three, or rather all four, all these features are part of what? Our major criteria. What are the criteria? Either two major or one major and two minor. So how many major? Two major, or we can use one major and two minor for diagnosis. Okay. Now what is NYHA classification? So NYHA classification is, remember, first is LPA. What is LPA? Limitation to physical activity. What are the classes? Class 1, class 2, class 3, and also class 4. What is class 4? It is basically sign and symptom at rest. What is class 4 is? Sign, symptom at rest. Sign, symptom at rest. Okay. Now in class 1, there is no LPA, no sign symptoms. Okay. On activity, no limitation. No limitation. He can do almost every activity. So that is the case. Then in 2, there is a slight or mild limitation. On ordinary activity, become breathless, but comfortable at rest. The word is here, comfortable at rest, in 2 and 3. And in the 4, is not comfortable even at rest. अब इसका कांड हो चुका है. He is sign symptom, severe LPA, and not comfortable at rest. So not comfortable at rest. Okay, ठीक है ना? Very easy. And there is what? And there is, yes, you can see sign, symptom, and features of heart failure. Features of Framingham can be seen, like S3, edema, increased JVP, etc. So all these can be seen in what? 4. So 4 मतलब गया. ठीक है? Now next question, what is the treatment? So inotropes are preferred for the systolic failure. So if systolic failure, we use inotrop. Don't use beta blocker. Beta blockers are contraindicated. तो color कर देता हूं मैं. Beta blockers are contraindicated in acute, decompensated or systolic heart failure. Why? They decrease the pumping and BP. Then next question, what is the other drugs we will use? We will use noradrenaline or dobutamine for cardiogenic shock. So drug of choice for cardiogenic shock in the heart failure is what? Noradrenaline and dobutamine. So what drug? Noradrenaline and dobutamine. Then what is the next drug? If there is a maintained BP, then we start ACE inhibitors. So remember, it is used if the BP is maintained. BP is normal. And if BP is low, we will give inotrop. BP low, less than 90/60. So if BP is low, we will give what? Inotrops. If BP is maintained, we start with ACI. Okay. Drug of choice is basically what? So drug of choice is ACE. Why? They prevent remodeling and they are best for decreasing the mortality and morbidity. And second best is beta blocker. Second best is beta blocker. Then we give loop diuretics. Why? Loop diuretics, example, furosemide. So loop diuretics are basically furosemide. Okay, they are for pulmonary edema. Beta blockers can be used in compensated chronic or diastolic heart failure where BP is maintained. If the BP is not maintained, don't use beta blockers. Okay. Now murmurs. So remember, the murmur is basically a marker of what? Our valvular lesion. So valvular lesion, or the marker? Murmur is the marker. Now remember, MR is similar to MS and AS is, MS, MR are the problems of which lesion? Of the mitral valve, and the ASAR are the problems of the aortic. They are on the left side. So they are on the left side. Right side heart problems are tricuspid, stenosis and the regurgitation. and pulmonary stenosis ring. Now remember, if they ask you causes, if it is present since birth, तो obviously अगर ये since birth है तो फिर ये आपका क्या होगा? If it is since birth, it is congenital. So it is congenital. Old people, it is degenerative. So old people is degenerative changes. And India, if they ask you, it is infection जैसे rheumatic fever young people में. और अगर पूछे वर्ल्ड वाइड, इट इज ऑटोइम्यून, और मोस्ट कॉमन पूछेंगे वो एसएलई है, ठीक है, एंड क्या नाम, सॉरी, एमवीपी, ओके, एंड मोस्ट कॉमन इज एमवीपी. सो व्हाट आर द मोस्ट कॉमन valvular lesion worldwide? It is mitral valve collapse. मोस्ट कॉमन इज mitral valve collapse. चलो लिख देते हैं इसका. निमोनिक है, मत पियो या माइटोकॉन्ड्रिया मेक एटीपी. तो निमोनिक याद कर लो, who make ATP? Mitochondria is the powerhouse. याद है, सबको आता है ये. MATP, इसका निमोनिक है M. Mitochondria make ATP. So most affected is mitral valve, AV valve, then TV, PV. Least is this. Okay. So mitral valve is the largest. That is why it is more chances of getting damaged and affected. क्यों? बड़ा है तो जल्दी खराब होगा. So that's why mitral valve is affected more. Now, investigation of choice. It is what? We are doing the echo, X-ray, ECG, MRI. So these are the investigation of choice in this case. Are you clear? Now, let's see the treatment part. If it is mild, asymptomatic, my suggestion is avoid what? Avoid exertion. So avoid the exertion. Then if it is severe, or there is a heart failure, or ejection fraction is low, then we will do surgery. And we will do valvuloplasty. So what we do? Valvuloplasty. Remember, so when do you do? That is the case. So first, mild or asymptomatic, just bolo, don't take any exertion. And if severe or heart failure or ejection fraction is low, then we go for treatment mainly, and also treat the failure or congestion etc. accordingly. Okay. Now what is the story? So understand, S1 S2 is systole, S2 S1 is diastole. तो बस को याद कर लेते हैं, फिर इस पे आएंगे हमारा. ओके ओके, आओ देखते हैं. फर्स्ट S1 S2 S2 S1, आओ देखते हैं. ये सिस्टोल है, ये डायस्टोल. याद करना, स्टेनोसिस इज ऑलवेज मिडल. तो क्या लॉजिक है? पहला, स्टेनोसिस इज मिडल, इज ऑलवेज मिड, बीच में आएगा बिल्कुल. और ऑब्वियसली इफ आयोटा इज नैरो, इट कॉज अ इजेक्शन मर्मर, सो इट इज मिड सिस्टोलिक. सो दैट इज व्हाई aortic stenosis is MSM, mid systolic murmur, mid systolic murmur, like this in the middle, and it look like a diamond. This is MSM, mid systolic. Are you clear? Same logic. If there is mitral stenosis, it cause MDM, that is mid diastolic, like this. It is decreasing, so it's called as a decrescendo. Why? Because as the valve is narrow, initially there is more sound, later the sound will decrease. Whereas in case of MSM, as the ventricle push, the sound will keep increase as it's pushing, more turbulence, and as the blood goes out, the turbulence decrease. So that's why you see rise and fall. Here we see only fall. Are you clear? Then next is, if there is a what? Mitral regurgitation, the blood will go back to the atria in which period? So remember, यहाँ लिख देता हूँ, अगर हो जाए MR, mitral regurgitation, blood goes to, तो क्या होगा? Blood goes to which structure, which thing? Blood goes to what structure? Tell me. So blood will go to what structure? Yes, blood will go to our atria. in systole. So it causes a pan-systolic murmur. So clear? So this is pan-systolic MR. तो इसे कैसे याद करोगे? वेरी सिंपल ट्रिक टू रिमेंबर इज व्हाट क्या है इसका ट्रिक? द ट्रिक इज समथिंग लाइक दिस. सो ट्रिक याद कर लो. Which subject you study about the IMR, MMR, PMNR? What subject you study mortality rate? PSM. So PSM भी study mortality rate और इसी में आएगा मरमर भी MR का. So MR is PSM, MR is PSM, MR is PSM. ये आपको हमेशा 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 याद रखना है, कभी भी भूलना नहीं. तो क्या करना है? Always remember, always follow this, never ever forget this. Are you clear? Done हो गया? चलो. And now if there's a aortic regurgitation, so obviously aortic regurgitation in diastole, in early diastole क्या होगा? Aorta recoil and push blood back to the ventricle. So क्या होगा इसमें? Aorta recoil and push blood into left ventricle. So push the blood back into the left ventricle. So blood will go back to the left ventricle. Done? So clear? Now let's continue. Now if the murmur occur in the initial part, this is the early diastolic. It is the AR murmur, early diastolic, EDM. Done? ये चार murmur याद करने हैं आपने. For the four murmur you need to remember, and also you can see the sounds like this sound and this sound. This is called as EC, ejection click. It is in MSM plus MSM, in AS, and this is our opening snap. OS is opening snap. Plus MDM in mitral stenosis. So ये उसके फंडे हो जाते हैं. Are you clear? So this is our clear. चलो. Now let's see. ये हो गया हमारा. Okay. So once again, what is the murmur of our ASPS? Mid systolic murmur. Okay. And in case of our AS, less blood goes to aorta and aorta cannot give to the brain. So syncope occur, angina occur, dyspnea. So remember, try याद कर लो. अगर mid systolic murmur is there plus there is a syncope, angina, dyspnea, diagnosis is clear. It is aortic stenosis. और the mnemonic is, it is आस पास देखो मत शर्माओ. आस पास mnemonic है आस पास. ASPS MSM, ASPS MSM, ASPS MSM. Are you clear? So then in the NEET PG, you are giving NEET PG after the FMG exam. Why? You want to get the MS or MD. तो याद करना MS mitral stenosis में क्या आएगा? Mid diastolic murmur. कौन सा आएगा? Mid diastolic. And also opening snap. So opening snap when the mitral valve open, and mid diastolic murmur is what feature? It is your MS feature. What is MS? Mitral stenosis. Then what is MR? MR is PSM. पढ़ा है ना आपको, PSM में मर गया. And the murmur is from S1 to S2. And remember, most common valve lesion which is seen is your mitral valve prolapse, MVP, which causes MR. So if there's a young female with acute panic attack and a murmur is increased on sitting or standing like this posture change, this is mitral valve. And what the murmur is? Again PSM. So if you get murmur, it is again PSM, pansystolic murmur. So pansystolic murmur in young female with panic attack, this is your mitral valve prolapse. Then AR. AR causes our early diastolic murmur. So which murmur? Early diastolic. Sometimes it can even cause mid diastolic. So what is having a double murmur? EDM or MDM? AR. This is called as Austin Flint. Austin Flint. So which murmur? Austin Flint. Now the signs of AR are, remember, collapsing or water hammer pulse. So what the sign is? Number one, there's a water hammer or collapsing pulse. Which pulse? Water hammer or collapsing pulse. Then there's Corrigan sign. What is Corrigan? Dancing carotid. What is Corrigan? Is dancing. The carotid is moving like this. Then there is Quincke sign. That is a pulsation you can see at the capillary called as the Quincke sign. Then there is Hill sign. The BP is different between upper and lower limb. Then you can hear very loud pistol shots over the femoral artery. Then there is Miller sign, lighthouse sign. So many signs are there. Okay. Okay. So treatment क्या है इसका? Treatment. Avoid exertion. Treat the failure, etc. if possible. Then yes, valvular replacement is last option. Before that, we can do valvuloplasty. So summary: MS, MDM, AS, MSM, MR, PSM, AR, EDM. And investigation, we do echo. Investigation, we do echo. चलो एक बार रिवाइज कर लेते हैं. आ जाओ. So मैंने आपको, if you people remember, have I did pediatrics for you people? Yes or no? बिल्कुल बिलाल. Have we done pediatrics? Yes or no? Yes. And there also I discussed ASD, VSD, congenital वाले. तो बोलना मत सर, वो तो कराया नहीं आपने. S1, S2, S2, S1. आपका काम है बताना कौन सा मरमर है. ठीक है, करें स्टार्ट. Which murmur is this blue one? Which murmur is the blue one? Which murmur? वेरी गुड. सो ईडीएम है. डिजीज का नाम बोलो. डिजीज AR. वेरी गुड. वेरी गुड. वेरी 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 गुड. EDM और AR. EDM और AR. वेरी गुड. चलो आइडेंटिफाई दिस पर्टिकुलर मरमर. ये वाला, ये फोटो आई थी एग्जैक्टली नीट पिचिंग. दिस इज pansystolic. डिजीज mitral regurgitation. एंड मोस्ट कॉमनली अगर पैनिक अटैक के साथ आई है, पैनिक अटैक, तो क्या सोचोगे? मिट्रल वैल्व प्रोलैप्स, MVP. बस हो गया. मिट्रल वैल्व प्रोलैप्स इजी हो गया. AR में क्या दिखता है हमें? बहुत सारे साइंस दिखते हैं. AR में क्या दिखेंगे? साइंस. कौन से? कोलैप्सिंग पल्स. ये वर्ड याद कर लो, कोलैप्सिंग. देन कोरिगन, देन हिल, एक्सेट्रा. बस जहां पे साइंस है ना बहुत सारे, ट्रॉपे, दिस ड्रॉजियो और दिस कोरिगन, हिल, म्यूलर्स, wherever the signs, it is AR. Very good. Then if this is the murmur, have a look. हुआ था वाईफाई सिग्नल. सो वाईफाई सिग्नल जैसा है ये वाला. ये कौन सा मरमर है? ये कौन सा है? MSM, mid systolic. So what do you think is the diagnosis? MSM. MSM. Yes, AS. For clinical feature, SAD. What is SAD? Syncope, उसको बार बार फेंटिंग होती है, एंजाइना, और क्या है साथ में? डिस्निया, ब्रेथलेसनेस. वेरी गुड. लास्ट बट नॉट द लीस्ट ऑब्वियसली इज दिस वन. ये वाला, ये वाला. ये वाला MDM, MS, MDM, MS. इसमें क्या होगा? लेफ्ट एट्रिया एनलार्जमेंट होती है. बस याद कर लो, लेफ्ट एट्रिया एनलार्ज एंड पल्मोनरी कंजेशन एक्सेट्रा. बाकी इको करोगे तो दिख ही जाएगा मरमर से. सो याद कर लो प्लीज, ये फोटो याद कर लो. आई डोंट नो, मगअप कर लो, पर आई वांट दिस फोटो पिक्चर टू बी इन योर ब्रेन. ठीक है. ट्रीटमेंट. What is the treatment? So treatment, I told you, valvuloplasty if it is needed. Otherwise, you can just ask them to avoid exertion. That's the main thing. Sure. Last is our ECG changes. If there's a flat line, so ECG kar raha hai. ECG. Flat line is called as what? Asystole. For the treatment, CPR with adrenaline. So once again, what is asystole? Flat line. So flat line is asystole. For the treatment, we will give CPR with adrenaline. If you see irregular, fast, irregular activity, fast, irregular, and patient no BP, no pulse, and no pulse, this is our VFib. क्या करेंगे? DFib. VFib, DFib. किसके साथ? With our, yes, high energy desynchronized DC shock. Then CPR and again DFib. Okay, for 2 minutes. CPR कितना करते हैं? At least 2 minutes. चलो. If heart rate is more than 100 and P wave is absent, it's a tachycardia. It's a tachycardia. And it is narrow QRS. If the QRS is narrow, it is our word लिख रहा हूँ उसके साथ में, narrow QRS is PSVT or SVT. So PSVT or SVT. This is a case. Drug of choice, adenosine, prophylaxis, varapamil. If wide QRS, abnormal wave but wide, this is our wide. If wide, this is VT. Wide is VT. We give amiodarone and lignocaine if requirement be. So क्या दे सकते हैं? Lignocaine if there is a requirement. तो क्या दे सकते हैं? Lignocaine. ठीक है. Okay. Okay. Next point. Now, if the treatment doesn't work, we can go for cardio version where we give electrical shock called as the synchronized DC shock. क्या देना है इसको? Synchronized DC shock. Now remember, if BP low, patient is hemodynamically unstable in both the condition, we will do cardio version. So फिर से इसको कलर कर देता हूं मैं. क्या है इसके अंदर? If BP low, unstable, cardio version. फिर से, if stable drugs, unstable cardio version. Unstable cardio version. चाहे वो AFib हो, A-flutter हो, VT हो, only in VFib we give the desynchronized call as the DFib, otherwise that. Are you clear? Chalo. Now, if you get sawtooth, that is 4 small sharp peaks and then one bigger one, it is atrial flutter. If there's a irregular pulse, no P wave, variable RR interval. RR is not fixed, it is variable. Then it is 100% what? 100% it is your AFib. It is your AFib. Now flutter or fibrillation. What is the main thing? Irregular pulse. If there, think of AFib. If it is regular but there is sawtooth, it's flutter. Treatment is simple. If stable, what we will do? If stable, we give the amiodarone. The drug of choice is amiodarone. That is amiodarone. Drug of choice is amiodarone. Amiodarone. For rate control, we can use the beta blocker or CCB. Or if heart failure, we can use digoxin. Okay, these are the drug of choices. Are you clear? Now, if the QRS keep changing in height, this is called as tossets. It's called as a TDP. Drug of choice become what? Drug of choice become MgSO4. Now remember, increase PR interval. Okay, is first degree AV block. How much increase? More than 0.20 seconds. Then if missing beats, it is second degree. Second degree, called as Morbits. Morbits. There are two Morbits. Morbits 1, the PR changes. PR changes and drop. And in Morbits 2, PR is constant and drop. Regular drop. So if QRS is constant, this PR is constant, then it is Morbits 2. If it keep changing and then drop, it's Morbits 1. And if no relationship, what is it called as no relationship? It is third degree. Treatment pacemaker. Treatment pacemaker. Are you clear? चलो, so with this we'll finish our cardiology also, neuro, nephro सब कर लिया हमने, ठीक है? So I think थोड़ा सा hemat बचा हुआ है. So I think hemat, you watch my YouTube video, and if I get time, I will do it what? In a rapid manner to you people. And now next we will do is PSM and also medicine test and discussion. Okay, so I think we'll take the medicine test and discussion within some 1 or 2 days, and we will then start with PSM etc. Okay, chalo. So I have to go to airport. I have a flight to Hyderabad for next 4 days. I have class there for NEET PG. So I'll meet you there. Class I can take from there also, but again I will be mainly asking you whatever I taught you in this 3 days is more than sufficient for medicine. No need to go to any other teacher. Do you think you will be able to remember whatever they teach you? The point is not the source. The point is how much you can take from the source. So my request is do only this much. Don't go for any सर ये सोर्स वो सोर्स, सर यहाँ से पढ़ लो वहां से, ओ भाई ये कर लो, ठीक है, आप ये करके दिखा दो ना, आप ये कर लो, दैट इज मोर देन सफिशिएंट एंड दैट इज माय रिक्वेस्ट इज, ठीक है. चलो, सो मिलते हैं. Yeah, only revision and the PYQs. Only revision and PYQs. So we've done our all the subjects. Only 2-3 are left. वो भी हमारा हो जाएगा. देखो TND almost all done. TND all done. Then क्या कहते हैं ये? This one. What do you say? Revisions are already going on. और भी ज़्यादा हो गए. Then last PYQs भी. And then the last we will do is what? Expected question section. I think that everyone is waiting for expected question where we'll cover 150 plus short questions for the upcoming exam. ठीक है, चलो. So I'll end the session. We'll meet very soon and I will be ending it now. ठीक है, चलो. So मिलते हैं बच्चों. Take care. Bye bye. Bye bye. Bye bye. ठीक है. I'll meet you soon. Yeah. Yeah. Puneet sir will do OBG revision whenever he get time. He was some busy in some, I think, some work. So once he free, he will take. सही है. Don't worry. चलो. Yeah. I will send this PDF in the group. Okay. Take care. Bye bye. Good